Welcome to CINP Young Psychiatrists panel. Today we focus on depression. We have already talked about cognitive dysfunction in depression and mood measured by rating scales, but we haven't talked about what really matters, and this is whether patients can function in their daily life, can go to work or school, how they function in their day-to-day relationship with their partners, family, children. So, Zheng, would you like to tell us more about that?
Sure. So, as Theo mentioned, depression is associated with a range of diverse functional impairment, including at work or school. They were associated with higher rate of unemployment, longer sick leaves, and also poor performance at work or school for different ages. And also they impair the social functioning, the relationship with their family, their friends, and also colleagues and society at large. So that's really matters for the patient and what really the patient struggle with in their daily life. So the question is, to what extent antidepressant treatment could affect this functional impairment in real-world settings? And there are some evidence from randomized controlled trials, but it's very limited due to the reason that, well, I think mainly due to two reasons. One is it's very difficult to measure these outcomes in a randomized controlled trial settings. And also the second is, to answer this type of questions, sometimes you need a little bit longer term studies rather than a few weeks. So that's why we probably have to rely on observational studies or epidemiology studies. But again, it comes to the question about in observational settings, the studies are uncontrolled. There are background factors or confounding factors could influence the association. But what we have seen from the literature is that there are at least some promising evidence showing that antidepressant treatment or SSRI treatment were associated with, for example, shorter sick leaves in depressive patients. And also, but for some other domains of the outcomes, the results are more controversial or mixed. For example, the result for school performance is quite mixed. And also for some other, social outcomes, relationship with their families and maybe partners, that's also very difficult even in real world settings. So there's also a lot of unknown there. And I think they also come back to the question about short-term and long-term effect of antidepressant treatment. So even in real world settings, what the evidence so far that is available in the literature is mainly about the relatively short-term effect within 1 year or 2 years. We see some improvement in terms of, for example, work performance or sick leaves. But there are two remaining questions. One is we see some improvement, but the extent to which are the patients already sort of back to their normal life, or they are still somehow worse than usual? And the other question is, in the long run, or if we consider the lifespan of that patient, could antidepressant really help the patient? Or does that antidepressant help the patients enough? Do they need some additional help, even in combination with psychotherapy or other form of care that could really help the patients in the long run?
So would you say that antidepressant and psychotherapy work for different patients, for example? A lot of people ask this question.
Well, yes, I think it's definitely work for different patients. We know for depressive patients that about 2/3 of them response to antidepressant treatment. There are about 1/3 treatment resistant. They probably respond to the new antidepressant, but I think psychotherapy definitely have an important role there. And another thing is that antidepressants probably work differently in different domains of outcomes. I think for some specific outcomes, for example, there are studies showing that psychotherapy actually works better if we consider work performance in the long run. So we have to also consider the specific outcome.
That's very
Would you like to
interesting.
comment on that?
Yeah, that's very interesting, and I agree. And also from a neurobiological perspective, we have seen in the study by Goldable in 2014, which is a very influential study and cited very often in the psychiatric textbooks, that CBT, cognitive behavioral therapy, which is a form of psychotherapy, and antidepressants work in a different way in the brain as well. So CBT appears to have a top-down effect, whereas antidepressants seem to have a bottom-up effect. And they are affecting different neural areas. So for example, CBT shows increases in brain activation in the hippocampus and decreases in the prefrontal cortex, whereas antidepressants have the exact opposite effect. So possibly also these differential effects on the brain areas might affect different mechanisms, different functions, might differentially affect mood. So that is something we need to also take into consideration.
So should psychotherapy and the depressant be used together then? What's your view on that?
At least in some patients.
And I think, yes, the gold standard of the guidance do mention that the combination between some patients is the most efficacious one.
I think it's very crucial as well to establish how severe is the depression. If we're talking about a mild depression, we can actually use only psychotherapy, or if we talk about a mild depression, maybe then we can combine or give the choice to the patient as well. But if we're talking about a severe one, we definitely need some help with the medication, isn't it?
Yeah, and the stage of treatment is also very important. And it has been well shown in studies that early on treatment, for example, with antidepressants, reduces the risk of relapse. I'm not quite sure if the same has been shown with psychotherapy, but we need to take that into account, like the time and the time course of treatment.
There is some particular patient, when, for example, the woman is pregnant, what do we do then? It's a very particular scenario, and we have to give all the choice, isn't it?
Yeah, exactly. Given that there are concerns about the antidepressant use during pregnancy and risk of preterm birth, birth defects, or even neurodevelopmental disorders in the offspring, like autism or ADHD, there's a big concern there. Although we don't sure if the observed associations are causal or not. That's a question mark yet, but it definitely there's a concern in the public.
Fredrik, would you?
Yeah,
you had a comment?
Regarding if a particular treatment is suited to one patient or another, I think there are at least two ways to look at that. And the first one would be, well, what do the studies say if we actually compare them? And as far as I'm aware, there isn't really that much difference. And no one is able to predict who will be better. There are some differences, like there's a meta-analysis by Pim Kuipers, which shows that for dysthymia, pharmacotherapy is much better. Whereas for obsessive compulsive disorder, we're stepping outside of depression, but then psychotherapy would be better than pharmacotherapy. This is all, there hasn't been too many studies done on all of this, so it's sort of sketchy still. But so we can't say which will be best for the patient, but there might be some support that the patient may be able to say so. Because one actual problem with the studies comparing psychotherapy to pharmacotherapy is usually that the patient knows precisely what they want. So if you look at a lot of those quite famous studies, like the Dimidian study in 2005, I think, that compared psychotherapy in combination, placebo and antidepressant, so a 4-arm study, you can see that those that were randomized to only get drug, you had a 14% dropout or a decline to participate. And that's not an uncommon finding. Mm-hmm. And when you look at it retrospectively, so people who are satisfied with their treatment assignment, when you assign them either to psychotherapy or pharmacotherapy, they tend to do better. And whether or not that's a true effect or whether or not that's sort of an artifactual thing of differential dropout due to not getting what you want. Like, say, for example, that you really want to have psychotherapy and you apply for a trial where you might get psychotherapy, but it's impossible to blind you to whether or not you're receiving psychotherapy, and you already know that you don't want an SSRI because you've already tried that and that didn't help you. Of course, you're not going to continue in that trial, or many patients won't. So it might be like we don't really know, but it could still be that the patients know what would serve them, what would be in their best interest.
Yeah,
And
that's
another
right.
important aspect is what is available as well, because in some countries the patients are likely to have all available treatments, but that's not the case worldwide. And it depends also the place and the city where they are. They may have different kind of psychotherapies. That's also a critical point, I think.
Yeah.
I find the point of taking into account also obviously the patient expectations is very, very crucial. And I think sometimes in clinical practice that might not be actually the case. So for example, patient stratification, different types of treatment, both within pharmacotherapy, like different antidepressants, but also in different psychotherapy or different types of psychotherapy is quite important. I mean, if, for example, somebody has some early on very prominent cognitive deficits, and we have seen in studies that even with antidepressant treatment they might persist independently of mood changes, then this person will eventually have problems in social functioning even after the mood changes occur. So we need to take that into account and possibly try to establish or find novel methods of actually applying patient stratification and treatment might be helpful. And coming from the clinical neuroscience background, I'm a very big advocate of taking into account the cognitive deficits and trying to find more reliable ways of measuring that, both in the lab but also in the clinic and with the patients. So
I think what you mentioned about patient expectation brings us another very important topic about placebo. So it come up actually in every roundtable, and I think it's worth commenting on that. Like, does any of you wanted to elaborate further?
I could say something, definitely. Placebo is a really complicated phenomenon in depression, because I would say that it's often misconstrued to some extent, because you really have to differentiate between two things, and one being the placebo response, which is everything that happens to the placebo group in a randomized controlled trial where you compare placebo to, for example, pharmacotherapy. And the other would be the placebo effect, which would be the specific effect that you get solely by being convinced that you might be given active treatment as compared to the realization that you are not then, or that you are not given that suggestion. And we really don't know what the placebo effect, what that specific sugar pill does. There has been some studies that have attempted to quantify this, that has done like time-matched controls, like a waiting list versus a placebo condition, and see to what extent those differ. And I know that Peter Götze, who is probably quite famous, has done one of those analyses and says that there is no placebo effect in depression. I don't believe that. I think it's a matter of which studies were included in that analysis, but that's sort of a point that needs to be addressed, because the other side of the argument is that other famous debaters or scientists like Irving Kirsch would say that, well, 75 to 80% of the response is a placebo response. But when you look at that, then you're looking at the natural variation of the disease. You're looking at, well, people who are probably entering the trials when they're at their worst, so there's a tendency for all patients to improve. That's not due to the suggestion given by the sugar pill, that's due to time. And you also have a range of other phenomena that might inflate the response in both groups, one of them being selective score inflation. And that's the tendency for raters to overrate patients at baseline so that they merit or warrant inclusion in the trial. So if you have a HDRS cutoff of 20 points, then what you can see is that raters who are aware of this cutoff will rate patients higher. It's a difference of 2 to 3 points on the HDRS as compared to raters who are unaware of the cutoff. And it's the same if you compare the raters who are aware to it with patients. So patients will also have a significantly lower rating of themselves as a group, and it's also within raters across time. So this is quite a well-established phenomena. And this too will add like a 10, 15, 20% placebo response depending on the sample you have. So it's very difficult to say what exactly the placebo effect is, but it's clear that the placebo response in an antidepressant trial is quite sizable.
Part of the placebo effect is ourselves, right? We prescribe ourselves. So
yeah.
That's another important aspect.
But that you could say is the therapeutic alliance.
Yes.
And maybe mine is overly conservative, but I want the placebo effect to just be the suggestion that you're being given a treatment that will help you. And then that the alliance or whatever confidence or trust that you have in your therapists that would be something else. To me, it seems like something that deserves to be independently modeled, at least.
Any other views on that?
I agree. I think you covered the entire topic.
So I would like to thank you for attending our panel, and I think we had very stimulating and interesting discussion about a hot topic as depression, and we focused on topics that are actually very important for trainees and early career psychiatrists. We are the young panel of CINP, so we wanted to give feedback and experience to help our colleagues worldwide provide better care, and we hope we'll accomplish that. Thank you very much.
Thank you.